Hi, everyone. My name is Dr. Jacobs, and I am teaching the mental health practice here at VCU. And today we are in Module 1, and we're going to be talking about mental health and culture. So, mental health diagnoses, mental health experiences, whatever word you really want to use, and words do have power. They occur through all cultures and all societies throughout history. Um, and it's really important to note that they, for all different people, mental health diagnoses have a variety of severity and nature, and symptoms can vary. Um, where, when, and how help is sought is really heavily influenced by a number of socioeconomic and cultural factors. There is no doubt that social determinants of health affect the state of health. And so I do want to briefly talk about what social determinants of health are. If you are sitting on the other side of the screen and you're thinking, Dr. Jacobs, I learned about this in undergrad. That's fine because some of you have learned about it and some of you may not be as familiar about it. If you are someone who is taking the mental health certificate here at the School of Social Work, then hopefully you are very familiar with it, but I don't think it's ever bad to be refreshed in this material. So really briefly, here's an image about social determinants of health. So social determinants of health, SDOH, are the conditions in which people are born, grow, work, live, age within, and these significantly impact an individual's health outcomes and quality of life. There is a lot of research in the US on social determinants of health. These are non-medical factors a lot of the time. They include your socioeconomic status, they include your education, access to healthcare, the physical environment, and they really play a crucial role in shaping health disparities and overall well-being. So my research in my doctoral program was about individuals in the school to prison pipeline and looking at the health disparities between a African American child who was engaged in the school to prison pipeline versus a child who was not engaged in the school to prison pipeline. And you're really able to see some major differences between the social determinants of health in those two populations. So as we're having conversations about mental health throughout this class, I think it's a great idea to think about social determinants of health. And as you work throughout your careers in whatever aspect of social work you end up in, don't forget about what social determinants of health look like. So let's get back to the conversation about culture. Cultures influence and contribute to the causation of mental illness. They mold symptoms, they render certain subgroups more vulnerable, as well as they modify beliefs, and they modify and shift explanations of mental illness. This demonstrates that cultural beliefs and values represent a crucial factor in mental health. There is a subsection of mental health called cultural psychiatry. It's not quite as popular in the States, but it is something internationally. Psychiatry is currently being used to describe the impact of culture and how that impact can influence the well being and functioning of individuals, including the ways that they express distress, the way they explain it, and the way that they seek help according to what they see as their problems. This includes a multidisciplinary approach to reaching a diagnosis, including an attempt to understand vulnerability factors, precipitating factors, perpetuating factors, and therapeutic engagement, which are all influenced by culture and culture outside of the things in this image that you're seeing here. In a lot of countries, the use of the term culture and its application is or continues to be perceived as solely relevant to Black and minority ethnic groups and individuals, which totally fails to recognize that every individual is influenced by their culture in the broadest sense, but also with microcultures. Culture has been defined in different ways, from the cultivation of crops to having shared meanings and knowledge. Cultures consist of learned behaviors and patterns which influence lifestyles, and being backed by knowledge and customs and beliefs and values, which go on to shape human behaviors, which influence in turn basically everything. And hopefully this connects to what you started to learn in your 601 class back in your first semester of your MSW. Um, so like I was saying, culture fluidly shapes human behavior, and then it's changed um, by when we are indirectly or directly in contact with other cultures. Cultures impact our lives in a number of subtle or not so subtle ways. We all carry our culture wherever we are. The way that we dress, the way that we speak, the way that we eat, the way that we think and develop are influenced by cultural factors. I'm from New York. I know I sound like a New Yorker. The more frustrated I get, the more I sound like a New Yorker. I carry that New York culture with me. First generation Italian, that's another culture I carry with me. I can keep going, but the cultures that I carry with me, they are integrated and they shape our worldviews as well. So I want you all to take some time. I'll give you about 10 seconds here to really think and reflect about the cultures that you carry with you and that shape your experiences. Um, so let's talk, I mean, in addition, there is little doubt that culture also affects the way that we experience distress and the way that we get help and who we get help from. Pathways to clinical care are really molded by the way that we understand the models of distress and then who we go to for help. Oftentimes, we seek help from personal folk or social sectors, and then once those are exhausted, we seek help from professional healthcare. This can also depend, and think back to the social determinants of health conversation we briefly had. This can depend on the type of healthcare system you have access to, the type of funding you have access to, which connects back to culture and society. In some cases, individuals with distress can use more than one healthcare system at a time if they have access to it. And then healthcare providers, so that would be me and then potentially you all, have their own beliefs and values and knowledge, as well as behavior patterns that are embedded in their own cultures and micro identities. And then looking at it from a larger perspective, geopolitical determinants um, are being recognized as important factors in developing and delivering medical care and physical well being. So, understanding all of these things come into play. There's been a lot of research post COVID about this as well. So much going on here. So, there's an impact of culture, and it's important to really tease out how um, we as providers understand how our beliefs, the larger beliefs of the systems that we're in, are going to impact the care that we provide. So, in the Western world, mental health diagnoses or conditions can often be seen as medical conditions, and that they need to be treated with medication or other medical interventions. But in other, let's say, Eastern cultures, or some people call them traditional cultures, mental health diagnoses can be seen as spiritual, and they need to be addressed through more religious or shamanistic rituals. So, understanding the impact of culture on mental health requires that um, providers, researchers, and clinicians challenge assumptions and acknowledge their biases and blind spots. If you have taken another class in the mental health certificate, hopefully this sounds familiar, because these courses are all going to ask you to think about your biases and your beliefs that you've developed up to this point. This is really important in the context of the Western biomedical model of mental illness, which really, as I've been saying, dominates research, clinical training, and the development of treatments. A lot of research study groups are relatively homogeneous. They don't reflect the world's cultural diversity. So, treatment protocols and evidence based practices that stem from all of this research reflect the same thing, which is why it's so important to continue to ask the question, both in class and post grad, who is this evidence based model developed for? Evidence that's derived from studies that are based solely on American populations produce findings that do not apply to all. If you're taking a practice to another country, for example, you have to ask the question, how effective could this possibly be without cultural adaptation. One example that has been used a lot or discussed in mental health is the example of emotional suppression, like when you keep your feelings inside rather than expressing them outwardly. In American and European populations, emotional suppression is associated with all sorts of negative consequences, both in the moment and long term. But we don't have any evidence that there are similar negative consequences in Asian populations. We assume here that expressing emotions is beneficial, but in Asia, there's this psychological data that underlying these assumptions are just not there. And there's a lot of research that in Georgetown that talks all about this. So, a constructed disorder suggests that, sorry, I have to take a deep breath. A constructed disorder suggests that cultures have their own ways of viewing mental health that may not be captured by or could totally contradict a biomedical model. So basically, what I'm saying is that Western definitions of mental illness may be too static to capture the range of human experience, especially when cultural difference is considered. In every culture, people express, measure, understand, and interpret psychological suffering in different ways. This is something that I really hope you're all going to note. Clinicians who have not been trained to apply a cultural lens and who fail to delve into a client, a patient's cultural context may end up misdiagnosing symptoms or missing symptoms altogether. This can lead to patients being prescribed drugs they don't need, not receiving the treatments they do need, or disappearing from medical care or therapy entirely because of cultural or language barriers. I've seen this happen in real life. These things tend to surface when Western clinicians and researchers make assumptions about what types of behaviors, attitudes, or norms are optimal, um, which has been called a sort of medical colonialism. So, an example of this is assumptions about how depression manifests can differ widely across cultures and communities. Um, by just going with your assumptions, we fail to see how cultures have ways of dealing with depression or distress that could be more effective in context. So, this is a quote from a professor at Georgetown. Chensova Dutton is her name, Dr. Chensova Dutton. She says, quote, cultures have developed a long history of adaptive strategies based on their own ways of understanding and responding to distress, and we effectively erase those understandings when we bring in our own, end quote. So in her research, she ends up talking about how American clinicians look at the connection between self-esteem and depression, and she talks about how we make this assumption um, that the Western understanding of depression is people who are not depressed should have a positive view of themselves. So then we train Chinese physicians to pay attention to whether patients are expressing feelings of worthlessness, when in fact that population's response could look really different. So I just want to wrap up here and talk a little bit about community. Um, Researchers have shown that people who experience schizophrenia and who experience auditory hallucinations may hear them differently depending on their social and cultural context. So again, this is research out of Stanford, and I found that patients who experience schizophrenia, um, the it was their experience was that their auditory hallucinations were more harsh and violent than those heard by people in India and in African countries, where the hallucinations were more benign. And some cultural psychologists and anthropologists believe that this was because in Europe and in America, there's a more individual like view of self. And versus in India and in Africa, which is a more community or relationship oriented place. So the voices that are heard there are less intrusive. Again, this is research, this is not my opinion. Um, and so the idea is that there's no question that how you see your community and the world plays a powerful role in how you see yourself. And so throughout history, in some societies, spiritual leaders, including shamans and prophets, have displayed some characteristics that bear similarity to schizophrenia. Um, and so in basically someone diagnosed with schizophrenia in the US could be considered highly creative, holy, or even magical in non-Western countries and could develop a very different framework for processing and expressing the same tendencies. So that's really my wrap up of this lecture. As you're working through the material in this class, this is the one module that's hyper focused on culture, but please continue to think about your biases, the way that you view things. If you're asking, who is this model adapted for? Where was it built? How can I adapt it to the community that I'm going to be working with? How does my culture come into the play in the way that I'm working in a clinician? So continue to ask yourself these questions, even if they're not directives in an assignment, even if they're not things that you're being asked to do from your agency, they will make you a better clinician. Thanks. All right. See you for the next lecture.